Hello, everyone, and I welcome all of you to the first Journal Club come clinical meeting by the Journal of Pediatric Surgery. For those of you I'm meeting for the first time, let me introduce myself. I'm Dr. Pallavi, a minimal access and bariatric surgeon based in Kolkata. And today I have the privilege of coordinating the JBS Show, which is what we call our webinar. Today we have some great speakers and guests. We will be doing the show in two parts. First, we will do the Journal Club moderated by our own Aussie President, Dr. Praveen Raj, and the Young Aussie convener, Dr. Nidhi Khandelwal. In the second part, we have an invited lecture of great interest by Dr. C K Huang, which will be moderated by Dr. Abhishek Kadakwar. You may be watching this either on DocPlex's channel or Facebook page of Journal of Pediatric Surgery. Wherever you are, most welcome, and please leave your comments in the comment box and we'll try our best to address them as we go ahead in our webinar. As we start with the Journal Club, let me first introduce our moderators for the Journal Club. Dr. Praveen Raj is the current Aussie president. He is the youngest Aussie president, an exceptionally gifted surgeon, and an equally accomplished academician. We also have Dr. Nidhi Khandelwal on board, who is a dynamic and extremely energetic pediatric surgeon from Mumbai. Dr. Nidhi is the convener of Young Aussie, which is the youth wing of Obesity Surgery Society. She is an exceptional surgeon, a very warm friend, and a very strict moderators of academic programs. With that, I hand the program over to Dr. Praveen Raj and Dr. Nidhi Khandelwal to conduct the Journal Club. All yours, guys.
So, good evening, friends. And I think to begin off with, I should start appreciating and congratulating the entire JBS team. I think headed by Dr. Raman Goyal, the editor of the JBS Journal of Pediatric Surgery. I think a wonderful initiative from Aussie and during the times of Dr. Manish Khaitan. And I think if already the first edition of the journal is already out. I think most of you would have already seen it. It's come out beautifully well. There's many more in the pipeline to come. And with not just being the journal, and I think I should appreciate the coordinators, Dr. Pallavi Priya, Dr. Aparna, and Tarun Mittal, for keeping the JBS show also on, just to keep the academic side of things going on, to keep connected with these surgeons across the lengths and breadths of the country and across the world, to keep this happening. So I appreciate all of you guys for this initiative and for the efforts taken in getting these academics on. And I think we are one of the few societies now we have our own journal, and not just, we have just gone to the next level of taking virtual education also through the academy. And I think it's an honor to be part of this event, and happy to moderate alongside Nidhi. Nidhi, any few words from you before we go on?
I think you've just very beautifully summarized exactly what the whole aim of our journal club is. I'm sure Dr. Raman Goyal will shed even further light on this later. Publishing is a very, very important part of a medical field, because this is how we learn about what's happening in the rest of the world. But of course, sometimes not everybody has got access to all of these journals, and that is why this journal club, which is an online platform, is going to be a very, very good idea, and it's definitely going to keep gaining more and more momentum. Now, without further ado, let me introduce our first speaker for today. Again, a very nice friend of mine. I've known him since his first day of MBBS, Dr. Amrit Nasta. And he will be talking about early weight loss, a determinant of total weight loss after bariatric surgery. Over to you, Amrit.
Thank you, Nidhi. I will just start sharing my screen. I hope the presentation is visible. So I'll go ahead. All right. So at the outset, I would like to thank Dr. Raman Goyal and the team of JBS for having me here, giving me this opportunity to present this paper, which we published in the journal in the first edition. I am presenting on behalf of Dr. Sijin, who could not be here. She is the first author of this paper. And what we will be talking about, what we published, is early weight loss. Is it a determinant of total weight loss after bariatric surgery? All right. So what was the reason for doing the study? Of course, being bariatric surgeons, we have faced patients, some of whom don't lose enough weight. And usually the weight loss is only in the first 1 to 1.5 years. There have been some data, some publications finding out what factors influence this maximum weight loss. May be related to age, gender, the genetic factors, like if the parents also had bariatric surgery and how much weight did they lose, what type of procedure, fat distribution, visceral obesity. So at the end of the day, there are multitude of things which affect weight loss. And yes, if you don't lose enough weight, perhaps even the metabolic effect of surgery may not be adequate. Once the weight loss period is over, that is the 12 to 18-month period after surgery, it is almost impossible to make patients lose weight after that. So if there is a way of finding out who are these patients early on, maybe in the first few months, if you can identify and whatever modifications can be made, maybe you can help them attain a higher nadir weight loss or more weight loss at the end of 12 to 18 months. So that was the whole background of doing the study, basically to identify, can we pick up patients early on after surgery, identify, okay, this is a patient who is likely to not lose enough weight, and maybe if we could find out some factors predictive, we could help them lose more weight at the end. But yes, this was a retrospective study of the patients who we had already operated on. So the aims of this study was to identify comparatively poor responders based on the weight loss in the early postoperative period, and to identify other predictors of weight loss at 1 year. So these were the main objectives of doing the study. This was a retrospective study. We picked up the data of all primary bariatric procedures done in the year 2013. Revision procedures were excluded. And we picked up those patients who had a 1 month follow-up weight as well as a 1 year follow-up weight. So this was the follow-up period. And we divided the patients based on some similar studies into two groups. At 1 month, how many patients lost less than 10% total weight? And at 1 month, how many patients lost more than 10% total weight? So these were the two groups we decided to divide and see, were these patients losing enough weight at the end of 1 year. So at 1 year was the timeline when we did the analysis. The results showed we had 125 primary bariatric surgeries at that time, of which sleeve gastrectomy was 108 and gastric bypass was 17. At that time, we were not doing one anastomosis gastric bypasses. Our selection criteria at that time were a little different. Our GB was done in lesser patients, mainly in those patients who had strong diabetes or who had GERD. Throughout the sample, the mean pre-op BMI was about 45. And what we found at 1 month, about 70 patients, that is more than 50% of the patients, lost less than 10% total weight at 1 month. And the second group, 55 patients, lost more than 10% total weight at 1 month. So these were our two groups whom we traced at 1 year. Did this less than 10% or more than 10% weight loss at 1 month make a difference? Both the groups were fairly matched, barring the age. The other parameters like pre-op BMI, the procedure that was done, that is distribution of sleeve gastrectomy or gastric bypass, presence of pre-op diabetes, they were similar in both the groups. Now, what we found was patients who lost less than 10% total weight at 1 month eventually ended up losing less weight at 1 year. Those who lost more than 10% lost more weight at the end of 1 year. And this was statistically significant. So the ones who lost less than 10% at the end of the year, they lost about 32% total weight loss, while the total weight loss in the group which had more than 10% at 1 month, at the end of 1 year, had about 38%, 38 kgs. We also did a regression analysis to see were there any other factors which affected weight loss at 1 year. So one thing we got from the previous slide was, yes, weight loss at 1 month is having a bearing on total weight loss at 1 year, and that is significant. Apart from that, another predictor was patients who had a higher BMI to begin with, who were super obese, they also ended up losing more weight at 1 year. The type of procedure, the presence of pre-op diabetes, and some other factors did not have much of a bearing on weight loss at 1 year. we went through some literature. There is not much literature on this. Yes, there are some published studies. Most of them are retrospective studies. So we also had a look at what those studies said, some of which we used as reference. So the first study I'll talk about, Manning et al. It was a big study on almost 1,500 patients, sleeve gastrectomy and gastric bypass. And what they found was that the percentage total weight loss at 6 weeks, 3 months, and 6 months is associated with more weight loss at the end of 1 or 2 years. So yes, patients who are losing more weight at 6 weeks or 3 months or 6 months are ending up losing more weight. Similarly, in the second study on about 150 patients, excess weight loss at 1 month strongly related with excess weight loss at 1 year and 2 years. The third study, a bigger study, this was the study we referred to when we got the 10% cutoff. So those who lost less than 5% at 1 month had a suboptimal weight loss at 1 year. And the fourth study, this was done in in adolescent population. They also found that in the age group of 13 to 19 years, this was a small study, 3-month weight loss influences weight loss at 1 year. So yes, there is literature to suggest of some extent that early weight loss is a marker of total weight loss at the end of 1 or 1.5 years. So to summarize some of the findings, what we found in our study, patients who lost more than 10% weight in the first month had a higher weight loss at the end of 1 year. Patients who were heavier to begin with lost more weight compared to patients with lower BMI at 1 year. On the other hand, at least in our study, age, gender, the procedure, preoperative comorbidities did not have much bearing on the total weight loss. So to summarize, what we got at the end of this is percentage total weight loss of more than 10% at 1 month has been identified as a predictor of total weight loss at 1 year. So when we assess our patients after this analysis, now if we find patients who are coming in early with not enough weight loss at 1 month, we are trying to counsel them more, call them for more follow-ups, maybe even start them on medications just to ensure that the maximum weight loss they achieve is good. So that was about our study. Thank you so much, and I will be happy to take any questions.
Thank you, Amrit. That was really great. If you can stop your screen sharing as well, please. Just had a couple of questions here. One, you said you based your study on one of the other studies which you quoted in your review of literature, where they considered 10% total weight loss as the criteria. Why this 10% total weight loss, and why did you not consider only excess weight loss or something?
There wasn't enough literature to get a clear cutoff. The other way of getting the cutoff, which other studies used, was a statistical tool where they use area under curve, receiver operating characteristics. But we didn't use that because those studies got that figure from weight loss at 1 year, and then they counted what should be the minimum weight loss at 1 month. We went the other way. We looked at weight loss at 1 month and compared it with weight loss at 1 year.
1 year, right. And how has this significantly changed your practice, and has any change in your practice, which you see is actually turned out to be fruitful?
So now we are starting to analyze that, because we actually came up with this analysis of this paper only a few months back. So it has definitely brought a change in our practice, and now we are starting more follow-ups in our patients. Maybe in the years to come, we'll get more data regarding, does intervention make a difference on total weight loss? That's what we intend to do.
Okay. And anywhere in this study, although I know you've not really studied it, but somewhere along when you were going through all your data, did you find any pre-op predictors?
Apart from BMI, so patients who were having a higher BMI, none of the others were predictive.
Okay, great. Dr. Praveen Raj, do you have any further questions for him?
Yeah, I think a very nice presentation, Amrit. I think, but then I have a couple of thoughts and questions. Number one, starting with the usage of the term percentage of total weight loss, because that is not something we commonly use in measuring. I think because what really happens is as the BMI increases, achieving 10% total weight loss is much easier to achieve or much more commonly seen. As the BMI goes down, the 10% total weight loss is much more difficult. And I think the opposite becomes true when you take percentage of excess weight loss.
Yeah.
So, why, I mean, I'll finish up the question. Maybe, you can finish it up. So why taking this 10% is some tricky when the BMI is on the lower end. And the second question is with regard to, I think you said because you've observed a trend of more than 10% per total weight loss, you get a much better outcomes. So you're now trying other interventions alongside to achieve this in the early stages. Could be just an observational kind of a data that patient who are supposedly going to have good results have achieved it at the first month itself. And by intervening, by trying to get that, this may not actually reflect in your outcomes in the long term. So these are two of the questions and thoughts.
Sir, I will take the second question first. Indeed, that is the problem with a retrospective study, where you can never be sure if your finding is just by chance or not. And one of the weakness of our study is it is a fairly small sample. But what we intend to do is maybe going down the line, do a prospective study where we can get the groups divided and intervene in one of the groups who have not achieved enough weight loss and have no intervention, and then study their trajectory.
Yeah. Great. I think lastly, one more question. Did you take the preoperative weight loss into consideration? Because if that had already happened, then sometimes 10% total weight loss might be difficult. So did you take that into consideration?
So we did not have that data since these were patients operated much before.
Okay. Yeah. Wonderful presentation.
Thank you, sir.
So Nidhi, if there are no questions, can we move on to the next talk?
Yeah. Let's just move on to the next talk. Praveen, would you like to introduce him?
Yeah. So I think Nidhi, can you go
Okay, fine. Okay. So I'll do that. The next speaker is going to be Dr. Prasanna Ramana Arumugoswamy. I'm sorry if I mispronounced that. He's from Dr. Sandeep Agarwal's team, and he will be talking about medium-term outcomes after Roux-en-Y gastric bypass surgery, experience from a tertiary care center from India. Over to you, Prasanna.
Okay, thank you. I'll be sharing the screen now.
Yes, please.
Just one second. Can you see my presentation is seen?
Yes, we can see it.
So thank you for giving me this opportunity to present my paper here. So I'll be speaking about the medium-term outcomes after Roux-en-Y gastric bypass, an experience from a tertiary healthcare center from India. This was done under the correspondence of Professor Dr. Sandeep Agarwal sir from AIIMS, New Delhi. Our co-author was Dr. Vitesh. A brief background, Roux-en-Y gastric bypass has been a highly effective procedure for weight loss, especially in patients with high BMI and multiple comorbidities. And we see that there is a high attrition rate in long-term follow-up.
Hi, Prasanna. Sorry to interrupt. Can you make it a full screen?
Is it not? Okay, one second. I'll just stop share once. Just give me one. Sir, is it full screen now?
Yeah, right. Go ahead.
So coming to the brief background, so as I was saying, there is a high attrition rate in patients who undergo bariatric surgery and especially RYGB in the long term, and limited data is available on Indian patients. So the aim was to study the medium-term outcomes after laparoscopic Roux-en-Y gastric bypass in an Indian population. So data was collected from a prospectively maintained database. All these patients underwent Roux-en-Y gastric bypass between the year 2008 and 18. We also conducted telephonic interview to increase the follow-up rate. Patients who opted for bypass, who had severe GERD, long-standing type 2 diabetes, BMI of more than 50, were preferred for Roux-en-Y gastric bypass. and all patients were operated by a single experienced surgeon with experience of more than 10 years. And detailed preoperative workup was done according to hospital protocol. So the technique, coming to the technique, a 30 to 50 cc vertical gastric pouch was created, an anticolic gastrojejunostomy of 3 centimeter width created with a elementary limb length of 150 centimeter and a BP limb length of 70 centimeter. And we closed all mesenteric and Peterson defects in these cases. Follow-up was done at 3 months, 6 months, 12 months, and then annually. For defining the remissions of comorbidities, ASMBS standard definitions were used, and all statistics was done using SPSS 25. Coming to the results, 142 patients underwent Roux-en-Y gastric bypass between 2008 and 18, out of which 17 patients had to be excluded as there were no records or they were lost to follow-up. So 125 patients were included in this study, and 107 of them had minimum of 1 year of follow-up. So coming to the baseline parameters, out of 125 patients, majority of them were female, making up 73.6% of the patients, and mean BMI was 45.5. The most common comorbidity noted was OSA, followed by type 2 diabetes, and then hypertension. So coming to the weight loss patterns, we observed that maximum weight loss was achieved at 3 years, with percent EBMI loss being 73.7% at the end of 3 years. The corresponding graph can be seen here. We also noticed that the follow-up rate also decreased. So at 3 years, it was 60.18%, and at the end of 7 years, it was 46.15%. We also noted super obese patients had significantly lower percent EBMI loss up to 2 years. However, beyond which there was no significant difference between the super obese and the non-super obese. Coming to diabetes, 50.9% remission was seen at end of 1 year, and it increased to 55.6% at 7 years. And also there was statistically significant decrease in mean FBS, HbA1c, insulin, and C-peptide. With hypertension, we saw remission in 63.6% patients at end of 7 years. And in OSA, improvement was seen in 66.6% at 7 years, with remission in 33% of the patients. In hypertension, we saw that there was a recurrence in one patient at 7 years who initially had a remission. Coming to the lipid profile, LDL, total cholesterol, and triglyceride levels significantly decreased at the end of 1 year, and the trend for triglyceride and total cholesterol levels showed a falling trend beyond 2 years also. HDL levels showed an increasing trend even beyond 2 years. Coming to the nutritional aspect of this study, we observed that anemia prevalence increased up to 4 years, and at 5 years it was 71.4%. However, there was no vitamin B12 or folate deficiency noted. But there was iron deficiency, which was 61.1% at the end of 4 years. Also, we noted there was no vitamin D deficiency beyond 4 years. Coming to the complications, so we had a 0 leak rate in this series, and we observed 6 complications which required management. So the one patient had lower abdominal wall cellulitis due to wound infection. This was within 30 days of surgery, and the patient was managed non-operatively with antibiotics and daily dressing, and the patient recovered well and was discharged. One patient had pulmonary basal atelectasis, which required prolonged ventilation and ICU stay. This patient also recovered and was discharged. One patient had internal hernia. He presented in the late operative period beyond 30 days, and this required laparoscopy with closure of the mesenteric defect. Patient recovered well and was discharged. One patient presented with intestinal obstruction features in the late postoperative period and was managed non-operatively. And again, this patient also was recovered. Stricture was noted at the GJ site in one patient in the late postoperative period, and this required 2 settings of endoscopic dilations, and after which the patient was relieved of the obstructive symptoms. One patient had staple line bleed. This was seen in the early postoperative period, and this required laparoscopy and control of bleeder, and recovery was uneventful. So we also noted 2 mortalities in this follow-up, and both were unrelated to the procedure and were seen beyond 90 days. So one patient had MI and the other patient suffered pneumonia. So talking about brief literature review. So in the present study, the percent excess weight loss at 5 years was 60.1%, and similar reports were seen in Indian study with 60.85% by Ismail et al. And in the Western literature, it's reported to be between 58.9% to 68%. Significant weight regain was seen in 9.6% of our patients at 5 years. From India, Beg et al. Reported 14.6% significant weight regain, and Obeid et al. From the Middle East reported 9% significant weight regain. So this study by Obeid et al., they had 328 patients, and higher percent excess weight loss was achieved by non-super obese patients compared to super obese in their study. And 19.5% patients had long-term complications which required surgery. So their data was a 10 to 13-year data. And all-cause mortality was 2.7% in their case, and they also reported decreased hemoglobin levels, iron, and vitamin D levels. In our study, however, the vitamin D levels did not show a decreasing trend. This study by Astro et al. With 10,000 patients, they reported a leakage rate of 2.37% in men and 1.68% in women, and overall complication rate was 5.6%. This study by Ismail et al., they reported the lowest BMI was achieved at around 3 to 5 years of follow-up, and at 5% excess weight loss was 71.5%, and weight regain was seen in 38.46% cases at 5 years in this series, and nutritional deficiencies were observed in 80% of their cases. So we had a small cohort. This would be one of the limitations, and also limited follow-up rates is one of the major limitations of the study. And in conclusion, Roux-en-Y gastric bypass is safe and effective for weight loss in the short and medium term in Indian patients with a low complication rate. So with this, I conclude my study. I'll be happy to take questions. Thank you.
Prasanna, that was a very good presentation, and just to because I think your results were quite interesting. Just want to know what is the based on this, would you be able to give any recommendation on what kind of patients you would prefer Roux-en-Y gastric bypass, or what's your institute protocols on selection of Roux-en-Y gastric bypass?
Here, what we usually prefer, first thing is the patient preference. If the patient prefers bypass, that would be one of the consideration. And along with that, higher BMI and multiple comorbidities, especially long-standing type 2 diabetes. And one more thing nowadays, what we consider is the liver. So intraop, if the liver appear diseased or cirrhotic, then it is better to avoid bypass. And initially, the patient are counseled for the change in procedure also. So we usually counsel them for all the procedures, and we let them know about the options and what would be the contraindication for these procedures. And if intraop there is a bad liver, we avoid bypass. Otherwise, if these criteria satisfy, we can go ahead. And also fibroscan is used nowadays to, in pre-operative period, we can actually counsel the patient. So if there is a high LSM or a cap value, then we can actually counsel them that the liver might be bad, so we may not be able to go ahead with bypass. So this is what we are following.
Okay, I know that is not the intent of this topic, but then since you have mentioned fibroscan, I think just to add on to the question, see, when we expect early grade 1 fibrosis or the early stage fibrosis, then it automatically means that is most likely a non-alcoholic fatty liver disease related liver disease that is starting. So which is obviously metabolic syndrome induced. And I mean, you just said earlier that if there is going to be a bad diabetes or more comorbidities, we would prefer Roux-en-Y gastric bypass, which is more so related to metabolic syndrome. I think why this change? I mean, even if it's early, you're going away from a bypass, but then on the other end, we feel for metabolic syndrome, you would choose a bypass. Why? I mean, what is that thought behind that?
But here at AIMS, we do not proceed with bypass if there is any evidence of a bad liver, because we have observed patients having bad outcomes. So that would be one reason maybe. And we usually prefer sleeve for such patients. And of course, the weight loss is good nowadays. I mean, we have data to support good weight loss with that. And in fact, reversal of grade 1 fatty liver is seen with sleeve also. So there is an ongoing study still with long-term results awaited, but so we'll have to see after that regarding those decisions actually. So what we follow is this here.
Thank you, Dr. Prasanna. Over to Nidhi. Nidhi, you are on mute.
Ma'am, I can't hear. Yes.
Sorry. Any concerns of GERD or hypertonia when you're selecting patients for RYGB? Because you didn't mention
Ma'am,
that right now.
Yes, ma'am. So if there is severe GERD, then we can go ahead with a bypass. So we usually go ahead. We would avoid sleeve in such patients, and we get all patients undergo preoperative endoscopy. So all the findings will be noted before posting for surgery.
Right, fair enough. And you mentioned that you had a significant weight regain around what 9%
Yes.
of your patients. That was
Yes.
at the end of 7 years, is it?
Yes, ma'am.
Okay, so what has been done for these patients? Have you ever had to revise any of these, any limb lengthening?
Actually, these patients were just followed up recently. Like we had called them for follow-up. So they're maintaining the same weight after it's not. Patient also do not want surgery. So for them, we have not done any further procedure, but counsel them regarding diet and exercise. But in some patients of sleeve, we have definitely undergone. They've undergone a conversion to bypass. Yeah,
okay.
But not
Right.
in these patients. Yeah. So actually, if I can share one case, actually, this is MGB case. We have got admitted that patient now. He's a pediatric case, 14-year-old boy. So he has come with significant weight regain. So we are actually planning a banding of the the sleeve pouch. The gastric pouch. So, and also a re-sleeve, excision of the dilated pouch if possible. So we'll have to see intra. So that is one patient we have actually admitted now. But that is in OAG. That's
Okay, fine. Maybe we can just save that for a separate discussion, and let's not dive too much into OAGB and banding of OAGB right now. I think we've had couple of really great presentations by two really young surgeons, and this has been a very encouraging first show by the JBS. And I think over to Pallavi to conduct the rest of the program.
Pallavi, you're mute.
Thank you, Nidhi, and thank you, Dr. Amrit and Dr. Prasanna. And I would also take this opportunity to congratulate Dr. Amrit and Dr. Prasanna for being a part of history by being published in the first issue of JBS. Congratulations.
Thank you.
Thank you, Dr. Praveen and Dr. Nidhi, for an excellent moderation. In the second part, we have a much awaited lecture on current status of sleeveless procedures by Dr. C K Huang, moderated by Dr. Abhishek. But before we start, I will ask Dr. Raman Goel to say a few words. Dr. Goel is the editor of JBS, and his hard work and vision, along with the support of the entire OSCE and the JBS team, has resulted in the inception of what is going to be a very useful journal in the pediatric surgery community. As we move forward with preparing our second issue of the journal and further activities, I would invite him to share his visions for the JBS team. Over to you, Dr. Goel.
Thank you, Dr. Pallavi. And the President of OSCE, Dr. Praveen Raj, Honorary Secretary, Dr. Kular, our guest speaker today, Dr. Huang, and the presenters of today's first journal club. So I think it's important to realize that this journal was started after significant deliberations. We have two very good established journals in bariatric surgery, but we realized that a lot of articles are not good quality, manuscripts are not getting published because those journals are overloaded with publications from all over the world. And they are ultimately ending up getting published in general surgical journals, whether from India or from other countries. So I think there was a necessity. And what we have done in the process, that we have made it an open journal. So this is the first open access bariatric journal in the world, where authors can publish without payments, and also readers can read through the entire published articles without subscription. And we intend to keep it this way. Now, I always had this vision in my mind the journal is not only about publication. Journal should be a vehicle to provide to develop a research attitude in the society, to create awareness about research techniques, and also about publication. And that is what our communication team with Dr. Aparna, Dr. Pallavi, and Dr. Tarun Mittal, we have been emphasizing that what we are publishing in a journal is one thing, but how we prepare our colleagues, our friends, young surgeons to collect data, to analyze data, and to publish it in journals is equally important. And that's why the JBS show has been conceptualized. Now, moving on to the journal club, I think journal club is a very important component, because the published articles are read by a very small percentage of surgeons or readers. Most of them end up reading only the abstract, and if they don't like it, they don't read the whole manuscript or whole article. So I think journal club brings these articles uh, to their homes. And since now we have the online journals, it makes it the online webinars, it makes it even easier for people to attend this and to hear the authors who have put in maximum effort, like let's say Dr. Prasanna and Dr. Amrit, for these articles that present their data, to have a discussion from two moderators, and to see whether the data that was published is worth their knowledge or worth learning from. So I think a journal club will go a long way. And what the way we have designed it, that every month we will have a journal club where we will have two published articles being presented by their authors and analyzed, and we will have a guest speaker each time, to so that we have some clinical inputs from an authority. I can't end without appreciating the reviewers who put in a lot of effort to review these all the articles that had come, which got published or which got declined. The entire editorial board, who has been, right from our chief editor, Professor Pradeep Chaube, Dr. Kamal Mahavar, and all the associate editors and member of editorial board. And obviously, this journal could not have seen the daylight without the support from OSCE, the OSCE president, secretary, and the entire general body of OSCE, which is standing behind to make this journal successful. So I think it's a long journey to make a journal run successfully over years, and I'm glad that I have the support of my editorial board and the OSCE in completely to make it happen. I'm very happy that today we have in the first journal club, the first guest of honor is Dr. C K Huang, who practically needs no introduction, because all of us have been watching his career, watching careers of his students who have gone all the way to Taiwan and are making big names in our country and many other countries. So I'm so glad that he agreed to speak about reviewing or to review the data of the procedure which he pioneered, and that will be a learning for all of us. So thank you so much for your patience, and we hope to see you every month in the JBS show, and to spread the word that the Journal of Bariatric Surgery is here, and to improve the quality of journal with your publications. Thank you so much. Back to Pallavi, please.
Thank you, sir. I did hear your words very intently, and I think we're all honored to be here. We are going to be a part of something big, and we are all looking forward to working with, inside, and for this journal. So with that, I move ahead, and let's go on to our guest speaker, Dr. C K Huang. Dr. Huang is going to be speaking on the current status of sleep plus procedure. And to moderate the session, we have Dr. Abhishek Katakbar with us. Dr. Abhishek is the Associate Director of Bariatric Surgery Unit at AIG Hyderabad, which is a very high volume bariatric center. He has also worked very closely with Dr. Huang, and both of them are expert in sleepless procedures, so that makes them a perfect duo for today's session. Over to you, Dr. Abhishek, to introduce Dr. Huang and conduct the session.
Thank you so much, Pallavi, and thank you, Dr. Raman Goel, for having me here. It's a great opportunity. And I'm sure Dr. Huang doesn't need any introduction, because if we count the number of Indian surgeons he has trained, probably he should be given honorary Indian citizenship. Uh, so I would not tell you about what great things he has done, but the thing which I have learned from him during my tenure, during my fellowship way back in 2015, I remember he told me that anybody can learn surgery. If you know GI surgery, you can be a bariatric surgeon. But the most important part in a bariatric surgeon is managing the post-operative patients, managing the complication, understanding the psyche of a person who is going through obesity, where there's a lot of social stigma, body image issues. And not only he made me a good surgeon, but he also made me a better human being. I met him as my teacher, but now I'm proud to say that he is a part of family. So with that, I welcome Dr. Huang. It's an honor to invite you for this lecture.
Thank you. Before my talk, I still want to congratulate on the OC and also Dr. Praveen Raj to be the youngest president, and Dr. Raman Goa on your success for your first issue of the JBS. It's very hard and difficult to start the new journal. And thanks for the invitation for me to attend the first JBS show. I think that would make a lot of valuable works to the surgeons, no matter it's young or senior one. I think that is make a very important online broadcast and also for the academic activities. Thanks for Abhishek as a moderator for my sections. It's an honor to become Indian citizen in the future. I would say my talk was assigned by the JBS Show for the sleep plus procedures. What does the current evidence say? I would like to say these items was start to be announced by us for sleep plus, the name. But I think that is really need times. I want to thank Abhishek to helping in writing this article to help the surgeons in the world to understand the concept. What is the sleep plus? It's because we have some problem for the procedure now. The first is about the sleep gastrectomy. Sleep gastrectomy is the most popular procedures, but his higher rates of the weight loss failure compared with the gastric bypass procedures. There's been a lot of studies showing that the long-term results after sleep is more inferior to the gastric bypass as the time longer times. And also for the type 2 diabetes controls, some well designed randomized study showing that the diabetes remission is also inferior to the gastric bypass procedures. But when we're looking at the gastric bypass, the second popular procedure in the world, it on the early and late complications. Gastric bypass have several short and long-term complications, like the dumping syndromes, marginal ulcers, internal hernias, iron deficiency anemia, and vitamin deficiencies. And some long-term complications are all related to a nutritional deficiency. We need the very long-term vitamin and mineral supplements. And dumping syndrome even was reported to affect more than 40% patients to have the dumping syndrome after gastric bypass. For Asian patients, lost higher gastric cancer occurrence prevalence area like the Korea, Japan, and China, I think the risk of the gastric cancer is a very important concern. A review articles showing that the remnant gastric cancer there's a 17 cases. Even it's rare, but all these cases become very late stage when we discover these problems. And the disease-related mortality rate is almost 1/3. So when you're thinking about sleep might be not enough, and gastric bypass might be have too much complications. So we start to think about how to use sleep plus to treat our patients. What is sleep plus procedures? It means sleep gastrectomy with concomitant additional bowel bypassing procedures to gain beneficial effects for weight loss and also the resolution of comorbidities. There's been a lot of old and new procedures, all belong to this group of the procedures, like a duodenal switch, loop duodenal switch, SEDIS, sleep with transient bipartition in Brazil, and sexy procedures from Middle East, the single anastomosis stomach ileal bypass with sleep gastrectomy, Roux-en-Y DJB with sleep, Japan, and sleep with loop DJB from Taiwan, and sleep with jejunal bypass, or we call the proximal jejunal bypass or jejunal bypass. It's also from South America. Sleep with jejunal ileal bypass, and also sleep with ileal duodenum ileal interposition. There's been quite large number of procedures we can categorize into this group. So you can see all different procedures, all was used by different surgeons, but the concept are the same. Sleep gastrectomy is the main component and aiding some bowel bypass. So about the evidence, what evidence say to gain from the sleep plus? The first is diabetes remission rate. To compare with sleep alone, when you aiding the sleep plus, like a duodenal jejunal bypass, if you use the ABCD score, those with poor response for diabetes remission rates after metabolic surgeries, you will see aiding the duodenal jejunal bypass can get more diabetes remission rates. So suggest aiding the bowel bypass would be for those patients with lower ABCD scores to achieve better diabetes remission. The second is about insulin user. In some study also shown those with sleep plus duodenal jejunal bypass can get the remission rate much higher for those who have used insulin before surgery. It's 72% compared with 41.9%. So for those with insulin-dependent patients, including lower ABCD scores patients with diabetes who need the surgeries, we will commend the sleep with duodenal jejunal bypass. And in fact, it's a more effective metabolic procedure. How to say that is about GI hormone changing after this aiding the bowel bypass. If you see these animal studies to compare with sleep and sleep plus duodenal jejunal bypass or only duodenal jejunal bypass, then what would happen to their GI hormones? You will see sleep rats, they would have good GIP enhancement, the same GLP-1 results compared with this aiding bowel bypass or only bowel bypass. But in these three group, sleep plus procedures have a lowest glucose, preserve insulin production, larger GIP hormones, and equal GLP-1 compared with the other two, and has higher bile acid concentrations. So the mechanisms of how diabetes get better remission might result in the bile acid concentration after you bypass the bowel. No matter it's in the BPD or DJB or gastric bypass procedure, or can showing this is the important mechanisms. Number 4 is about less late complications. When we compare with the sleep with loop duodenal jejunal bypass with Roux-en-Y gastric bypass, at 1 year, they might have similar results in the HbA1c groups, and HbA1c drop and fasting glucose and mean BMI. But however, the complicated marginal ulcer and dumping syndromes is much more compared with the sleep plus procedures. So let's let complication make the sleep plus more worthwhile to do. For the beta functions, in this same study, showing the HOMA beta cell functions is increased significantly after 12 months of surgeries. And in gastric bypass groups was not significant increased. The lower diabetic relapse. So compare with the sleep plus, including duodenal-jejunal bypass or the jejunal bypass or sleep alone, you will see the sleep with DJB and sleep with JJB exhibited superior glucose tolerance and very similar insulin sensitive to sleep alone. This is animal study, but according to the results showing both these sleep plus procedure can have superior diabetic control compared with sleep alone. Then is the better weight loss. I think for bariatric surgeons, we did not only want the patient at 50%, 60% excess weight loss. All the patient wants better weight loss. If better weight loss also means long-term maintenance of the comorbidity resolution is better too. In the 2019 retrospective studies for those with morbid obesity, compare with sleep and sleep with jejunal bypass and Roux-en-Y gastric bypass. It's showing that sleep with jejunal bypass at highest total weight loss and excess weight loss compared with sleep alone. Even it's very similar to the Roux-en-Y gastric bypass. Okay, but when Roux-en-Y gastric bypass compared with sleep with jejunal bypass, they have higher rates of anemia, vitamin D deficiencies, vitamin B deficiency, and also hypoalbuminemia. So you will see sleep plus procedure has better weight loss compared with sleep, but less complication compared with gastric bypass. Of course, rare dumping syndromes because of the preserved parose in sleep plus procedures. Almost there's no instance of dumping syndrome in this group versus 7.6% reported in Roux-en-Y gastric bypass patients. So it also have higher instance of diarrhea and complaint of fatigue. It's almost double to 3 times. The last is about for Asian patients. The incidence rate of gastric cancer was quite high in Eastern and Central Asia. So it compare with the North America and also compare with Africa, you will see it's almost about 6 times difference in East Asia. Especially in the Republic of Korea have the highest national incidence of almost about another doubles new cases annually for the males. So in this semi-review just published last year, you will see it's showing that sleep plus, no matter it's status or sleep with duodenal bypass or with the sleep with jejunal bypass, it can have almost similar weight loss results compared with gastric bypass, but cause fewer complications than gastric bypass. And some sleep plus, like sleep with DJB and sleep SEDIS procedure, even have better weight loss compared with Roux-en-Y gastric bypass. So this is the 10 years trends in our centers. I'm going to share to you. We have 3 main operations in these 10 years. Every year we do about 300 to 400 cases. And in the beginning, the sleep plus is zero since 2010. That times we have very large numbers of gastric bypass every year, but it's decreasing slowly when the sleep gastrectomy start to gain the popularity. So in the highest numbers is going up to the 262 in 2014. After that, it means that after about 4 to 5 years of sleep, we start to see some weight regain and some not very good diabetes remission in comorbidity remission. We start to incorporate more sleep plus procedures. Very interesting is that gastrectomy bypass right now in our hands every year now is going to only 7 cases a year, and sleep gastrectomy has declined, and sleep plus take over this advantage about the volumes. So we also have some revisional surgeries. So, but the trend is going up for the sleep plus procedures. Sleep still does very important roles, but becomes second importance now. We almost abandoned the Roux-en-Y gastrectomy bypass already. So my conclusion is sleep plus definitely will gain popularity after higher adoption of sleep gastrectomy. But sleep gastrectomy is inferior in the weight loss. And for Roux-en-Y gastrectomy bypass has more complications, and sleep has worse diabetes remission and also in the relapse. In the near future, I think it will replace the gastrectomy bypass that ever treated as a gold standard procedure in the worldwide. And how to select in so many different sleep plus procedure selections, I think should be according to the variety of patient's condition, and also in different surgeon hands when you have different ability to do various procedures very maturely. I think that would be your choice. It's my opinion and my talk. Thank you very much.
Thank you, Dr. Huang, for covering these 10 points in favor of sleep plus procedure. So I have 2 questions for you. Being a moderator, I will be the first to ask you. The first question is, a lot of people have doubt about blind loop syndrome and SIBO in procedure like proximal jejunal bypass. I know that we haven't seen it also in my practice, but I want to hear it from you. The second question is sleep plus procedure, because as a trend seen in your practice, you don't do RYGB anymore and no scene of MGB there. So don't you feel there is some geographical difference comparing, Indians are the bulk eaters, and the amount of food and the quality of food which we consume here is totally different, because I've seen Taiwan people, I've seen the portion size and the type of food they eat. So you feel that same thing can be applied to Indian, or will there be some difference?
Okay, about the blind loop syndromes, I think a lot of surgeons concerned about these issues, but when you look at one literature was published by Munier, that he had to go into for second reoperation for sleep with jejunal bypass. He tried to sample the blind loop bowels, but he did not find any bacteria overgrowth in this area. And the second is that, yes, till now we have done about 700 cases of sleep with proximal jejunal bypass. We did not see the blind loop syndromes till now, and it has been observed for more than 7 years. So if you really encounter blind loop syndrome, if you look into the literature, blind loop syndrome did not occur in this kind of procedures. In fact, in Roux-en-Y gastrectomy bypass, in duodenal switch, when you bypass the duodenum, when you bypass the remnant stomach, it still have the possibility to have we call it blind loop syndromes. When you have some GI tract was closed, sealed, without the food it enter. So, but the rate is really very low. So for some concerns from surgeons or patients, I would tell them that if it really happened, you have some symptoms of that, you can convert it to the normal small bowel. It's very easy to convert it, or we can resect this blind loop. So I think this is not a really big issue till now. And about the food preference, I love Indian food definitely, but of course very high carbo and also very high fat. So I think gateway bypass patients have some problem in India because you have large vegetarian and most is carbo, very low protein food. So in fact, if you do gateway bypass, the patient will be encounter more hypoalbuminemia in the futures. The protein deficiency, I think, will be much more, and anemia too. But if you do sleep plus procedure, I think it would be better compared with Roux gateway bypass. And I'm not sure that whether it could be like a duodenal switch or only just like doing proximal jejunal bypass. But in Taiwan, we think that we are, as for myself, I have been changing my concept for bariatric surgery now. I don't think that it is malabsorption procedure. I think it's important to change the bowel hormones to make the patient have a more long-term satiety, so make the weight loss is better, maintaining the long-term weight. So right now for the sleep plus procedures, even we use the plus as a revisional surgery for the sleep weight regain cases, but you did not see much malnutrition issues. So I think for the food prevalence, I think in the future, Indian surgeon will be able to answer this, but I think sleep plus procedures still much better compared with gateway bypass in India.
Thank you. Any further question?
Abhishek, can I ask him a question?
Yeah, please go ahead, sir.
So, CK, excellent talk. Really enjoyed. My only concern is that increasingly we are finding more and more sleep patients ending up with de novo GERD, or they had GERD symptoms before, but anatomically they were normal, and they developed GERD severity increased after surgery. Now, when we are talking of sleep plus procedure, this particular element of sleep is there common in all the sleep plus procedures. So how do you manage that, and what is your experience?
Okay, for the sleep reflux, I think there's been a few publications about de novo GERD after that. And yes, in the first 5 years of my sleep gastrectomy, it's really bothering us. And when we start to look into how to more aggressively treat the patients, the hiatal hernia, you will see that the incidence could be decreased a lot. Right now, for us, we ask the gastroenterologist to more aggressive to look into any element of the hiatal hernia before surgeries. During the surgery, we aggressively to open the hiatus and close it very tight. Before, most surgeons use H-bones or non-absorbable sutures to close it, maybe 1 or 2 sutures, without tightness, because of worrying about strictures. But right now, we close it very tight to let only 1 centimeter distance for the hiatus closure. This means that we did not remain the big opening anymore. And we found the instance of reflux decreased very much. And the second is that the de novo GERD, a lot of surgeons say, in fact, the anatomy might be still normal, but the patient has GERD. But in fact, when you do the CT scan, you will see a lot of patients develop the migration of gateway tube. It might be only 0.5 centimeter or even 1 centimeter, but it causes migration and causes the GERD at the night. So in this kind of cases, to prevent it, there's 2 issues. One is repair the hiatus aggressively. The second is when the hiatus, you close it, your gateway tube was pulled down, you have to fix your gateway tube to prevent the future migration. Because when the patient start to lose weight, sometimes the muscle wasting make your hiatus to become wider. So if you did not fix it well, you think about when the patient lose 40, 50 kilograms, the muscle wasting can cause the new hiatal hernia. And when you did not fix the tube migration causes a new GERD. So right now, we encounter very few reflux issue anymore because we do more aggressively on this. So next time, if we got chance, I can share the video to all to see how we manage that. But right now, because our procedure Sleep Plus become Sleep Plus account more than 95% of our patients, but GERD now is not a problem anymore.
Oh, that's so good to hear. Okay, Abhishek, over to you.
Yeah. Any other question, Dr. Kullar?
Yeah.
I know because he's a proponent of FDB. I was expecting a question from him.
First of all, I must congratulate Dr. Huang for such a nice presentation. Just to ask, like amongst the Sleep Plus procedures, which is the commonest one which you are doing in your practice?
In fact, for Sleep Plus, mostly in our center, we do sleep with duodenal bypass, loop one. And another one is sleep with proximal jejunal bypass. But sleep with proximal jejunal bypass become the first priority now. This is the main two operation we're doing.
What is the, understanding behind this? Why are you choosing this proximal jejunal bypass over the duodenal bypass?
We use the different severity of diabetes.
Okay.
So when the patient diabetes longer than 5 years, the patient's fasting CPAP less than 2, we would do duodenal jejunal bypass. And also those who use insulin case. It's very similar to the ABCD scores. Those who is severity diabetes is much more than we would bypass the duodenum. For those who is more early diabetes, relative good beta cell function preservations, do not use insulin cases, we would select only jejunal bypass.
So if you have to revise a patient with the DJB Sleep Plus, so it's easy going, or you find it, what is the complication rate, or how frequently you're doing it?
Okay, we have published a few papers of DJB versus gastric bypass. The dumping marginal ulcer in the DJB cases almost 0 to 5%. But for the gastric bypass, in these two complications, almost about 10 to 20%. And when you compare with DJB versus proximal jejunal bypass, there are differences about the diarrhea. And also the iron deficiency is more in the DJB because of duodenum bypass. In sleep with proximal jejunal bypass, the nutritional deficiency is much similar to the sleep alone. I think that is because we did not bypass the duodenum and we just shortening the jejunum limb. It means the total length of the small bowel changing is in the jejunum and ileum parts. So the adaptation of the small bowel to nutritional absorption can occur very soon. But when you bypass the duodenum, that causes problems of the malnutrition, including the calcium, iron. You will see that in your patient's problems.
Yeah. Good. That's quite interesting, and congratulations for the good work which you are doing. And another one, if you have a pre-existing significant GERD, so still you will go ahead with the Sleep Plus procedure, or you have a different choice?
Preoperative, if the patient have GERD C, then mostly I would persuade the patient to go to the Ruai gastric bypass. But GERD C is very rare in Taiwanese patients. But for those who preoperative, the patient presented with GERD, but the patient have hiatal hernia. No matter it's GERD A, B, C, D, even there's some barrettes, I still can do Sleep Plus. We have some data showing that even the patient have barrettes, but it's coming from your hiatal hernia anatomy problems. When you repair it tightly, you do Sleep Plus, the patient still can get remission of it, their barrettes. So I think when anatomy issues, you correct anatomy, then the patient don't have the issue anymore. But if it's because of some diet habit problems or some unknown reasons of pirates or severe GERD, then I still recommend the patient to get the Roux-en gantry bypass. So gantry bypass still not totally abandoned in our center. You will see in 1 year, we may do about 10 cases. Most is because of these kind of issues.
Good. Thank you.
Thank you.
Thank you.
Livy, you want to speak?
Thank you, sir. Thank you, Dr. Abhishek. Thank you, Dr. Huang. I would like to start by thanking you for accepting our invitation and delivering this excellent lecture. And we would definitely like to see your video on the procedures in our future program. So it has been a great webinar. I would also take this opportunity to announce the date of our next webinar on 21st of June, and we are going to have an excellent program then as well. With that, I hand over the program to Dr. Kular. Dr. Kular is the Secretary of the Surgery Society of India. He is one of the pioneers of one anastomosis gastric bypass and has been the first publications on the subject from India. Over to you, Dr. Kular, to conclude the program.
Thank you, Dr. Palvi, and I must thank everybody, especially congratulate Dr. Amrit and Dr. Prasanna for their first presentations and publications. And I thank Dr. Nidhi, Dr. Abhishek, Dr. Praveen, Dr. Huang, and must congratulate and really salute the efforts being done by Dr. Raman Goel for this JBS, and especially, bringing up this JBS show. This is quite interesting and quite impressive and encouraging as well. And I can assure you, Dr. Goel, that from Aussie, there will be full support to the JBS. And anytime you need any kind of help from my side, I'm all out for you. Thank you very much.
Thank you.
Thank you, Dr. Kular, and a very good evening, good night to all of you.
Thank you so much.
All again very soon in our next webinar.
Thank you so much.
Thank you so much.
Bye-bye.
Bye-bye.
Thank you.
Good night.
Bye-bye.
Bye.